All right. Yes, we are live. Welcome to Women Reclaiming Their Health. I'm Coach Pam B, certified health and wellness coach, and I want to see women win the war over their health despite their age, setbacks, and challenges. And we have with us today Dr. Ansari, cardiologist, and the topic is Our Hearts Matter, because they do, ladies. Okay. So before I go ahead and I'm going to get my disclaimer out the way, any information obtained from this group is not intended to be a substitute for professional care to treat, cure, prevent disease or illness. Okay. So if you're joining us live, if you would like to comment, go ahead and click on the StreamYard link and give permission so that we can see your comment, your name. If you're catching us on the replay, go ahead and type in replay. So let me introduce Dr. Ansari. So from an early age, he knew he had a need to serve others, particularly those lacking access to quality health care. By choosing a career in medicine, he could directly affect the most change for those individuals. He trained to become a cardiologist because it would allow him to dramatically alter the course of a disease and immediately impact the lives of his patients. Dr. Ansari treats the core illness and symptoms of heart disease for adult patients with a particular interest in heart failure, valvular heart disease, coronary artery disease, and hypertension. He has received extensive advanced training in both cardiovascular disease and echocardiography. Dr. Ansari's expertise in cardiac imaging allows him to provide an extra level of care to his patients as he utilizes imaging technologies such as echocardiography, cardiac CT, and cardiac MRI to accurately diagnose disease and determine a treatment plan. Dr. Ansari enjoys working collaboratively with his patients to develop individualized goals and treatment plans. He feels strongly that gaining a better understanding of his patients will lead to a higher chance and success for a healthy life. And of course, he enjoys spending time with his family. He has a beautiful wife and three beautiful children. So, without further ado, let's give it up for Dr. Ansari. Woo. All right, all right, all right. So I know I just gave a whole book about you, but in your own words, tell us what you enjoy most about what you do. Let me make sure you're not muted. Looks like you have the mute. I think you are muted. I think you're muted. Okay.
There we go.
There you go. Now your mic's connected. Yes. Okay. So yes,
Yeah,
what you're doing most.
Pam, thanks again for having me on. And I'm not sure if everybody is aware of our history,
Yeah.
but Pam's known me for a few years now at the hospital, and
Mhm.
I always give her a hard time anytime I see her. And it's really nice to see you in this other role and everything. So first and foremost, it's really nice to talk to you like this. And thanks again for that introduction. I basically am first and foremost a clinical cardiologist. So my role as a cardiologist that doesn't do interventional procedures such as stents and angiograms, my role is to actually intervene in my patients' lives and their well-being, to kind of make sure that their health is optimized, specifically from a cardiac standpoint. So what that means from like a day-to-day basis is I see patients, and I see patients either in clinic or I see them in the hospital, and that can be a general medical floor or an intensive care unit setting.
Mhm.
And then when I am seeing those patients, I basically assess what their active or chronic cardiac condition is, and then kind of hopefully in a collaborative manner decide how to treat it in terms of what is possible and what actually is in their best interest, to try to again optimize their health.
Mhm. Awesome. Awesome. So, of course, this is about women. All women right now. We're focusing on. I know you deal with men too, but why do you think heart disease is the leading cause of death in women? Is it our lifestyle? What do you think from a physician's standpoint?
So it's interesting, from an epidemiological basis, historically, women have been concerned about breast cancer and whatnot. And then in the last decade or so, it looks like heart disease has unfortunately become kind of the leading cause of mortality, certainly, and then perhaps morbidity as well. There are a couple of things that are going on with kind of all genders that we're seeing. One is there's quite a frank epidemic of heart failure, and heart failure is a disorder that affects kind of the middle to elderly age population disproportionately. So when you look across the country and look at patients that are in the hospital from a cardiac cause, probably half of them have a diagnosis of heart failure, actually.
Wow.
And then coronary artery disease, which kind of mimics the traditional risk factors that men have. So smoking, perhaps, but then the obesity-related disorders, so diabetes, you can think of. There's a very strong link to that and coronary artery disease. And so women, just like men, kind of as the time has progressed, we see kind of this uptick in weight in both genders, and so women are not immune to the kind of development of this.
Okay, I think your mic hit your mic again.
Okay, hold on one second. They're paging me from the hospital. Let me just clear the page.
Okay. Oh, I knew it was gonna happen, Doc. I had a feeling.
Yeah.
Guys, hold on. Bear with us. He's got some medical situation right now. So.
All right, hold on.
Thank you guys for being on. The ones I see, there's a few of you guys on. There's 10 on. Hi, Star.
All right.
Hi, Janice. All right. Okay. Yeah. So
I should be back.
Awesome. Okay. So what are some symptoms? I'll try to go through these pretty quickly because I think you might be called away soon. So what are some symptoms?
No,
I know
don't worry.
chest pain. Okay. The left-sided, the sweating. Like, what are some symptoms that we like rule out as, it's stress, or it's heartburn, it's acid reflux,
Right. So the symptoms specifically in women can be very minor or very kind of atypical. There is, I think people should try to make two differentiators. One is if they have just coronary artery disease that has been developing for years and is likely due to age as well as other risk factors, so high blood pressure, high cholesterol, diabetes. So as we all age and we have their risk factors, there's a good correlation with developing blockages that are chronic. And this situation is a lot like a house that has plumbing that's 40 years old or 50 years old, and you start to see some blockages over time in the plumbing. And so then you turn on your faucet and there's not a lot of good water pressure there. So when would you call the plumber in that case? Well, you wouldn't call them Sunday morning because, it's going to be an extra hassle and an extra charge. You would just wait. It's nothing new. So when it's that situation, then patients, I would say, probably present typically. And that means they'll have either chest tightness or pressure that occurs with exertion and goes away with rest. And then it will be reproducible. So you are climbing that hill, and every time you're halfway up the hill, you start to feel a little pressure in your chest and maybe some associated shortness of breath with that. Then there's another type of blockage that's more of an unstable issue, and that is completely random. It occurs in patients with risk factors. It occurs in patients without risk factors, which is kind of scary. And this is an unstable syndrome where someone might be at high risk of a heart attack or developing what we call an acute coronary syndrome, where they could be at high risk in the next 2 weeks. And those are very kind of odd or disparate type of symptoms. So someone could present just with sweating. They could have nausea. They could have arm tingling or jaw pain or whatnot. They could feel just unwell and tired or whatnot.
Mm-hmm.
And so I usually tell people if you have two of those symptoms, so maybe you don't have a history of heart disease, and then you start to feel some shortness of breath, and then for no reason you're also feeling nauseated at the same time.
Mm-hmm.
And you're like, gosh, this is really weird. I don't know what's going on. So those two kind of symptoms at the same time that don't have kind of a common denominator, it actually might be your heart.
Gotcha. Okay. So someone is asking a question. Looks like Lisa's asking, should we be alarmed if our blood pressure spikes during exercise? She's saying not normal exertion, but a spike where you can feel it pounding in your head. So is that a sign? Mm-hmm.
So the normal, when you're doing aerobic exercise, the normal response is for your blood pressure to go up.
Mm-hmm.
People that have baseline high blood pressure could have a problem when they exercise.
Mm-hmm.
Generally, the number that we worry about when you exercise is a top number of 220.
Gotcha.
Okay, so that seems really high because normal blood pressure is 120.
Mm-hmm.
So normal is 120 over 80. So if you're at 220, that's almost double what a normal person's blood pressure is. And people frequently, when they exercise, develop that top number 160, 170, even 180. And they
Mm-hmm.
usually don't feel any symptoms from that because that's a normal response.
Mm-hmm.
But if you have high blood pressure at baseline and you exercise, then you can kind of get it to a markedly abnormal number, and then you can possibly feel some symptoms of that. A way to double check that when we do stress testing, so it's a very simple test where you basically walk on a treadmill.
Mm-hmm.
We actually have you hooked up to an EKG and a blood pressure cuff. So people actually don't appreciate the fact that there's a blood pressure cuff that's hooked up to them as well. And we check what your blood pressure is doing when you exercise.
Mm-hmm.
And so we can measure it at every 3-minute interval, and we can
Mm-hmm.
see if your blood pressure is getting into that danger zone with exercise. And that way, if it is a problem, if it is something that we call a hypertensive response,
Mm-hmm.
then we can treat it.
Awesome. And then now we have Tara asking, is there a heart test we can do to get checked? I know there's like the 24, 40-hour monitors, the 30-day monitors, and yeah.
So there is, if you're over the age of 40 and you do not have a history of heart disease like blockage, but you think you're at risk, so you might have a strong family history of heart disease, or your parents might have had a heart attack at a young age, or maybe you have a sibling that's had a heart attack or a stent or something like that. There's a very quick test called a calcium score that you can actually ask your primary care doctor to do for you. And this is a test that is not approved by insurance. So kind of all over the country, the insurance companies have gotten together and decided that they're not going to pay for this test. But because of that, and because of supply versus demand, and how hospitals run their businesses, most hospitals only charge $100 for this test. And so while that isn't an insignificant amount compared to most cardiac testing, it's markedly cheaper. Right. And this calcium score, basically, it's nothing to do with having kind of thin bones or osteoporosis that your primary care doctor might scan you for. This is a test where we actually put you in a CAT scanner, which is a big X-ray machine that's shaped like a donut. And literally in 2 minutes, we performed an X-ray of your heart's arteries. And that's what that CAT scan shows us. So it's an X-ray of your heart's arteries, and we're basically looking to see if you have coronary calcification. And this test can be positive 10 years before a stress test is positive. And it really changes the way that we look at patients. So if I have a 50-year-old patient and she tells me that her parents had horrible heart disease, and maybe she has a little obesity or high cholesterol, but feels fine and exercises and was living her life, and asks me, well, hey, what can I do to make sure I'm not at higher risk, and I'm not a statistic where something bad happens to me and I'm one of those people that had no idea. The first test I would recommend in that case is something called a calcium score, and it's a very quick test. It gives us a lot of good information. It's relatively affordable as well. And it can really change the way we
hit your mic again. Turn your mic back on.
Yeah, I might be back. So they're continuing to want me. But so then this test, basically, in the same 50-year-old woman scenario, the score might come back at 0, in which case I could tell her, hey, you actually are at low risk and your 10-year prognosis is very good. Or the score will come back at a non-zero number. And the score can be anywhere from 0 to, I've seen scores of 3,500. So if the score comes back over 400, that's a high amount. That's markedly abnormal. And then we would look at that person differently, and we would want to treat them aggressively to prevent further blockages from forming.
Awesome. Okay. So I'll get into the procedures here in just a moment. But somebody's asking about blood pressure checking at home. How many times a week should they check it? Are they checking it multiple times a day? What do you recommend as far as checking our blood pressure?
Yeah, if we just want to kind of get a pattern. So checking it, I think, multiple times a day is too much. Okay, most of the time I'm telling my patients, just give me a few readings per week. And they can be at random times because your blood pressure fluctuates throughout the course of the day. But it's more to just see a pattern to decide if your numbers are overall high or if your numbers are overall low or normal. And I definitely recommend using an arm blood pressure cuff. And there are a few companies that have affordable products that are quite accurate. So one of them, and I don't speak for any company of any sort, but one of them is called Omron, OMRON. That's a pretty good blood pressure cuff that's affordable, and it's usually just behind the pharmacist's counter at either CVS or Walgreens or Kroger's or something.
Okay.
And so I think if you check that, again.
I think he got paged again, guys. I think he was getting paged. So yeah. So thank you all for your questions, for your comments. We're appreciating those. Is he back on?
Okay.
Okay. All right. He's
Yeah,
back
should be
on.
back.
Okay. Awesome.
But
okay,
yeah, so
okay.
if you check it maybe just a few times per week, just to get a pattern going, I think that would be really the best thing.
All right. Okay. And then, okay, great. So as far as the procedures that you do, I know they go from the low intensity all the way up to so can you just give us those ones that you do for your patients to manage the block?
So I'm a non-invasive cardiologist, and the way cardiology is now is there's specialties within the specialty. And so as a non-invasive cardiologist, I have additional training in imaging. And so basically I do CAT scans, I do MRIs of the heart, which is a kind of a very small niche right now. I do echocardiograms, and I do nuclear stress tests of the heart. And so I do more of the diagnostic end of things. And then you have interventional cardiologists. They're the cardiologists that come in the middle of the night. They treat like heart attacks while they're happening. So they get called from the emergency department that a person is having a heart attack, and they basically take the patient for this procedure called an angiogram or a cardiac catheterization. And during this procedure, they take images of the heart's arteries using iodine dye, and then they deploy a stent or two if needed for the blockage. So that's an interventional cardiologist. And then you also have electrophysiologists. So the interventional cardiologists are the plumbers. The electrophysiologists are the electricians of the heart, and they do pacemakers and defibrillators, and they treat atrial fibrillation with ablations. We also now have heart failure doctors that manage people getting heart transplants. And so they manage all the medications and the who, what, and where of heart transplant. They also facilitate patients that get mechanical pumps for very poor heart function and heart failure. And so those are probably the 3 or 4 main subspecialties within cardiology.
Okay, so I know we talked about blood pressure. We talked about some lifestyle things as far as like weight and watching our numbers, diabetes, watching our blood sugar. So I guess I was going to ask you, what can we do to reduce our risk for heart disease? And I guess you pretty much said it, like keep track of your numbers. Do you have anything else to add to that?
Yeah, so I think keep in mind a lot of this is more or less, I won't say exactly genetically based, but there's a genetic predisposition and there's a familial predisposition to it.
Mm-hmm.
Probably about 25% of what we have is modifiable. Probably 75% of it isn't, in terms of just lifestyle, in terms of diet and exercise. Okay. So the first and foremost thing is you have to know your numbers, first off. Mm-hmm. If you have diabetes and you don't know it, that's horrible. Mm-hmm. If you have high cholesterol and you don't know it, or if you have high blood pressure and you don't know it, that's really horrible. Mm-hmm. So the first thing in the first place I would start is really something in terms of primary care, to see your family practice doctor, your internal medicine doctor. And you have to ask them, check me for diabetes, check me for high blood pressure, check me for high cholesterol, all the things that you can kind of modify. And if you find, significant abnormalities there, then those have to be treated. Mm-hmm. They're asymptomatic. You won't know if your sugar is 250 a lot of times. You won't know if your cholesterol is 300. So it's very common that a lot of these kind of diseases that we accrue as we age are asymptomatic. Mm-hmm. And so on a yearly basis, because just because you got checked a year ago doesn't mean, now you don't have it. So basically on a yearly basis, you should be screened for all of these issues. Awesome. And then once you make sure you don't have like a serious underlying medical condition that can put you at risk for heart disease, then you can focus on the other 25% aspect of it, which is the lifestyle, which is diet and exercise. And then diet is very tricky because there are so many different dietary recommendations that get put out. Mm-hmm. And I tell my patients, look, the dietary recommendations change year from year. Mm-hmm. So a good example might be an egg. Previously eggs were good for you. Then all of a sudden eggs became bad for you. Mm-hmm. Then the yolk was bad for you. Then the whole egg was good for you again, and whatever. So it kind of changes. Mm-hmm. From year to year, but the exercise recommendations don't change, Mm-hmm. And so getting about 150 minutes of exercise a week at a minimum has been consistently the recommendation.
Okay, I think your mic dropped again. You dropped.
Got me back?
Got you back. Okay.
Okay. Yeah, has consistently been the recommendation from the American Heart Association. So I would start there as far as a low-hanging fruit from a lifestyle recommendation.
Mm-hmm, mm-hmm. And now with the stress, do you think, are you seeing women, what do you do when they come in there, then they're stressed? Do you think that, no matter how much we exercise and how much we do all this stuff, do you feel that women just carry more stress? Are you seeing that from your patients as well?
Yeah, these are interesting times. I definitely have to say that. I'm seeing it both men and women, young and old. So people are really kind of under, pressure from a lot of what's going on these days. Mm-hmm. It is important to have an outlet for your stress, and exercise is a good outlet. But talking to your healthcare team, either your primary care physician or someone else, if you don't have that family member, I think is very important. But stress as an underlying risk factor for heart disease is a true thing to concern yourself with.
Mm-hmm. Okay. Well, I just want to thank you for your time. See, I told you it wasn't going to be too bad. So yeah, thank you. We got through all the glitches. Okay. Hey, we got through it. We worked through it all. Thanks so much, Josh. Thanks everyone for joining us. Health is the new wealth. Goodbye. See you at the next session.